I want to thank each of you for joining us at the Children and Family Services Administration Equity Forum Virtual Town Hall. That Equity Forum was held on June 9, 2020, and the title of that Equity Forum was COVID-19's Impact on the Black African American Community. The forum was pre-recorded. Children and Family Services Administration is an administration of the Minnesota Department of Human Services. This is a recording.
Just a little bit about the CFS Equity Forum for individuals who are not a part of our DHS CFS employee community or staff. Just a little bit of background about the forum itself. Our mission is to bring together staff in addressing disparities, root influences and causes and impacts to those disparities, to share information that creates awareness and inclusive spaces, tackle social and governance challenges, and to enrich the quality of life. My name is Verona Mitchell, and I am Director of Equity and Inclusion at Children and Family Services Administration. And that administration is a part of the Minnesota Department of Human Services. And I will be serving as your moderator for today's forum. So let's get started with today's panelists. I will give a brief introduction of today's panelists, and then the panelists will come and go live and introduce themselves, give some information about their background and how they came about doing this work. And I think this work, it centers on equity and inclusion and diversity and understanding how COVID-19 is impacting a very diverse community. And so they will give their background on the subject as well as their credentials and how they came about this work. But for right now, I'm going to give you a brief introduction of who those individuals are that's serving on our panel today. Today we have medical doctor Keith McKinney, and Dr. McKinney is a faculty physician at Health Partners Occupational and Environmental Medicine Residency. He's an affiliate assistant professor at the University of Minnesota School of Public Health and a clinical investigator with Health Partners Institute.
Good morning. Thank you for the introduction.
Okay, thank you. Next we have Betty Hillard. Betty is the Health Equity Specialist at the Center for Health Equity at the Minnesota Department of Health. Betty is also the Cultural and State Community Engagement Contract Manager and Community Liaison. Welcome, Betty. Good morning.
Good morning. Thank you, everyone.
Good. Next, we have, as a panelist, Devin Gilchrist. Devin Gilchrist is the supervisor for the newly founded African American Child Wellbeing Unit at the Minnesota Department of Human Services. African American Child Wellbeing Unit is housed within the Child Safety and Permanency Division at Children and Family Services Administration. Devin, good morning and welcome.
Good morning, everybody.
All right. And then we have as a panelist, Dr. Karen McKinney. Karen is the Chief Equity Officer and an Assistant Commissioner at the Minnesota Department of Human Services. Welcome.
Thank you, and good morning.
Hey. So for right now, I'm going to go live and stop sharing my screen here and go to our live stream with our actual panelists. So you can hold just 1 minute until I switch over here. So actually go live with our panelists. a whole bunch of boxes. Okay, I'm gonna start off by having medical doctor McKinney share his background and share his background and some information about Dr. McKinney. Dr. McKinney, you are on.
Thank you so much, Verona, and thank you to everybody at DHS and CFS for having myself and the others here for this forum. As she said, my name is Zeke McKinney. I actually grew up here in North Minneapolis. In some degree, growing up there, made a lot of disparities in health and environmental justice and some of the social issues that we see become very apparent for me, and that made my work going into medicine some way want to interact with our Black community and be able to help them to some degree. I did all of my medical training here in Minnesota, both medical school and Master in Health Informatics at the University of Minnesota, which I finished in 2011. I did an internship in general and trauma surgery at Hennepin County Medical Center, and then proceeded to do residency in occupational and environmental medicine at Health Partners, which is where I now still continue to work. Occupational medicine is primarily a field involved with environmental hazards, whether they're at work and you consider them to be occupational or outside of work and they're environmental. But of course, these types of things affect us all profoundly. As far as some of my work that may involve the Black and African American community, my department is actually doing some research looking at health disparities in workers. We've been collecting detailed demographic data more than your sort of Black, white, Asian, Native American, Hispanic data that you'll collect in your most electronic health records, but instead letting people identify themselves as Somali, Ethiopian, Hmong, a lot of very specific ethnicities where we can start to see are there disparities and how workers are being affected. Additionally, with respect to the coronavirus pandemic, occupational health has come more to the forefront where people are interested in how do we maintain safe workspaces and safe environments out there. My specialty is one of public health, and so in that regard, we've been working a lot with businesses and with schools. Personally, I work a lot with first responders, trying to make sure that they can do their jobs safely and continue to protect us during this very difficult time. In general, I think there are a lot of health issues affecting the African American community, and it requires medical and public health professionals to be able to give useful information, relevant information, so people can feel like they have the resources available. I apologize if that was too long.
No, that was just right. It gave a context to what we're going to be talking about today, and it set the tone. And I'm glad that you are from the area. We need to start celebrating our own, and I am I am thankful that you are from the area and you can get back in this place. So thank you so very much. We're going to have Miss Betty Hillard come to us and give a little bit about her background and how she comes to this city.
Hi, my name is Betty Hiller, and I work in the Center for Health Equity at the Minnesota Department of Health. I partner with the Office of Diversity and Inclusion, and I lead on cultural events. I've been a state employee for 26 years. We've all been at the Minnesota Department of Health. Spent the last 6 years working on health and racial equity. I'm one of the racial equity trainers at the Minnesota Department of Health. It's a mandatory training for all employees. We have 1,500 employees, and 1,100 have already had the racial equity training. I'm very committed to changing the lens in which we do public health and making quality health care accessible to all. My work on this COVID response has been working with 4 African American contractors in the community as well as the faith-based community to make sure that they get accurate and timely COVID messaging that has been provided by the Minnesota Department of Health and some from the CDC. COVID changes rapidly, so we share messaging weekly with our contractors. We share, and they share it with the community through their social media and websites, whether it's their Twitter, Facebook, Instagram, podcasts. We're just trying to get the message out out to the community, and we did this very fast as soon as COVID came up. MDH is working with the governor's community resettlement and to identify and create solutions to make sure Black and other populations of color and indigenous communities are not worse off after COVID, and to have desegregated data so that we can know what is happening in our community. We are also very dedicated to, but we just believe that community leaders and community voices are the best ways to engage communities. We provide a two-way communication channel to get out not only the information we want to get out to them, but also information that they bring back to us from the community on what their needs are, what their concerns are each week. And we try to provide some kind of guidance on that. Whether it's, you've seen all kind of guidance coming out of Minnesota Department of Health, from the social distancing to the hand washing to the covering your cough, to how to go grocery shopping, to guidance. We get guidance on how to close the churches, and now we're working on guidance on how to open the churches back up. COVID has just been rapid with all of us, but it has really affected the African American communities, not only here in Minnesota, but all over the country. And so we know that we are disproportionately affected by COVID. And so we have to do our part to make sure that we stop the spread of COVID, make sure that the messaging gets out that this is really serious and we all need to take precautions on how to not spread it. Because even though it may not affect, it does affect young people, whether they believe it or not. There are some of the higher numbers of COVID confirmed cases. They may not be as deadly for them, but they are being confirmed cases. There are some of the higher cases. And so we just want to get the word out. We did, I just wearing masks, and that was a whole big push. And we had different thoughts on why we should or should not wear masks, especially in the African American community. We know that we're held to a higher standard, and so masks have and bandanas have been associated with the bad people, with the bandits and stuff. And so to ask us now to wear masks and stuff, it was a little undertaking. But as we've discovered, it's not really that big of a step, because we were hearing that our youth didn't want to wear masks. So I found out that the youth will wear masks if they were accessible to them. We have a community where we were saying everybody's going to have to wear masks now, but masks weren't accessible. So we've been really doing a push to make sure that the masks are available in the community, because you can't give us a problem and not share a solution with us. So I'm really grateful that the masks are out there now. And then our next big act was the testing. And now that we're getting testing out in the community, and I just want to share that this week, and you can look for cases to go up, because this week we have 4 different sites where we're doing community testing. In North Minneapolis, it's New Salem Baptist Church, and the testing will be from 12 to 6 today and tomorrow. And then at Holy Trinity Church, the testing is going to be from 12 to 6 on Tuesday and Thursday. We have the Jimmy Lee Option Rec Center in St. Paul. Testing will be today and tomorrow from 12 to 6.
A lot of companies. Yeah, that's
so the cases are going to come up.
I know. Well, hold on to that, Betty. I want you to come in at the community, on that community section that we're going to have with questions, so that people can have time to get a pen and paper and or type in all those locations and times on their computer so they can have them. So I want you to hold on to all that information, and then we're going to circle back on the community section to relay all that information, because that's a lot of rich information. Okay, Karen McKinney, you're up next. Just give a brief introduction and how you got to this place. Karen, you are, hold on, I'll unmute you. There you go.
Thank you for unmuting me. I forgot to unmute myself. I am Dr. Karen McKinney. I am new in state employment. I haven't even reached the 6-month mark yet. I came on, and for 5 weeks I worked in the Department of Human Services, and then we I am tasked as Chief Equity Officer to deal with equity and anti-racism. I have a bachelor's degree in English literature. I have a Master of Divinity degree. I have a Master of Education degree. And I have a doctorate degree in educational leadership. So I come from being a professor for 25 years. I also come from being a consultant on anti-racism for about 30 years. So I have taught on this topic, and I have also consulted with churches and schools and businesses and nonprofit organizations for the last 30 years. So I'm coming at this from that angle, and I'm looking at the internal DHS and transforming the culture there. So looking at also at how COVID impacts our people, the people, the employees at DHS, because that's kind of the domain that I'm going to be working. So I'll be coming at this from that angle.
Yeah, thank you so much, Karen.
Oh, and I'm also a North Sider, like the other Dr. McKinney, and I'm born and raised in North Minneapolis. My family has been here for over 100 years.
Great. Okay, now we have Devin Joseph going to come to us and give a little bit about background and the work that he's doing.
Yeah, hello. Hope you guys can hear me. Okay. Yeah, I'll be brief with this thing. So once again, I am Devin Gilchrist. I am working at DHS. I am the supervisor of the African American Child Wellbeing Unit, and I'll just give a brief one-sentence description of what that is. We can discuss more later on. And so that unit basically is created, brand new unit created to kind of oversee and ensure that there are culture affirming practices around prevention, family preservation, child welfare, et cetera, to support African families to address disparity and disproportionality, and to create a responsive and appropriate system for our families. Because we know that lots of our families are involved in the system, much more than white family committee cases. And so this unit is created to create some space and some efforts to address that in a very targeted way. And I'll get to more of that later on in the discussion. I also am a Minnesota native, Minneapolis native. I'm a South Sider by nature, so but I tell folks that my North Side card is very much in effect. So I grew up in South Minneapolis, but I also went to school on the North Side. Played North Commerce Park and Hospitality House, and went to Henry for a short period of time and Washington. And so I have experience on both sides personally, with both North and South Side. But I am 100% a South Sider. I currently live 3 blocks from 30th in Chicago, so I grew up in this area, and I live currently in the area right near where George Floyd unfortunately lost his life. So this is my community. My background educationally is in communication, sociology, and social work. For the most part, for the better part of my career, I've worked pretty much exclusively with Minneapolis and St. Paul families. I would say probably 90% have been African American. Through nonprofit, education, county work, and now state employment. And this is my second stint with a state agency. So I've been at DHS for now, this is now, I think, finishing my 6th year next week, I believe, working in the child welfare arena in CFS, which is Child Safety and Permanency, working in quality assurance, and then working as the foster care policy specialist for several years now in my current role. And I came to this space kind of obviously for my current role and my commitment to working with my community and trying to address the issues, and then also think about how COVID impacts the community and that intertwines with social services and whatnot, and in child welfare too. And so I'm also leading a work group at DHS to look at how we better support the community around COVID needs and COVID-related issues, not just currently, but also down the road too, as this continues on, because we are nowhere near out of the clear yet. And I just want to add that that work group consists of a number of individuals within DHS, from child care, child support, economic support, Medicaid, Then also working with Betty's department as well as partnership. And most of those folks are African Americans, and these are folks who are leading these areas, these divisions. So they're folks that have a vested interest personally and professionally in the community. And so our whole thing is to make sure the community has access to resources, services, needs, has an understanding of what things changed within policy and practice to support them through the COVID process. And then also we can hear from the community as to what they need as well and continue to develop responsive solutions for them as we move through the pandemic. So that's all I'll say for now, and I'll let the rest can be addressed later on in our discussion.
Yeah.
Thank you for having me here.
Thank you. Thank you for your service. And it's just so good to see that we're giving back. We are state service workers. We are civil servants. And it seems like I'm the only transplant here from New Orleans, Louisiana. But I like the richness that Minnesota has, and it is diverse to me. And we're going to keep on doing what we do and helping every family, but also acknowledging the beauty of our differences and the beauty of culture and diversity within this space. So I want to thank you all. Medical Doctor McKinney, we've heard that this COVID-19 is like the flu, it's going to go away, it doesn't happen in heat. What exactly is COVID-19 from a medical perspective? What is this that we're dealing with right now?
Sure, I'm happy to answer. And part of my job as a physician is to try to make sure I bring information to the level of my audience. So if for whatever reason I end up being too scientific, please feel free to either interrupt or ask follow-up questions to make sure that I'm communicating this effectively. But essentially, I mean, it's in the name. Coronavirus is a family of viruses. They are categorized in a bunch of scientific and biological ways, but suffice it to say that many of our common colds are part of that family. So there's probably about 4 strains of coronavirus that we see fairly commonly. Less commonly, we've seen a couple different or new novel coronaviruses in the past decade or so. One was SARS, which, if everyone recalls, back in about 2003, was affecting Southeast Asia, and they were wearing a lot of masks. I actually happened to be traveling through there at that time. More recently, we saw one in the Middle East that was called MERS-CoV, which was, for another coronavirus. And now, more recently, so the old SARS was called SARS-CoV. That was the name of that virus, and this new one's called SARS-CoV-2. And so the actual disease is called coronavirus disease 2019, which that's what the abbreviation COVID 2019 comes from. CO being corona, vi being the virus, and D being disease, and then the 19 being the year. So COVID-19 is just the name of the disease representing this new and novel strain of coronavirus from this year. But overall, this larger family of viruses, coronaviruses, are common in people and in a lot of different species of animals, cattle, cats, camels, bats. Rarely do they spread from animals to people and back and forth, but people can infect other people. Ultimately, they tend to be from an animal reservoir initially, and then there will maybe be some mutation that brings it over to people. And so that's the belief of what happened when this virus started out in Wuhan, China, and eventually made its way globally here and elsewhere. So right now, CDC, of course, is working with everybody to investigate cases and try to define better the science about this. You've mentioned, is there going to be a second wave or something about the flu, like similar to what we see with the flu, seasonally or annually? We don't really know yet. There are some data suggesting both that it may not come back or that it may come back. Right now, we don't really understand very well how well people develop immunity. For example, when you think about the influenza or the flu virus, every year there's actually multiple strains of the influenza virus going around. And when they design the vaccine every year, it's based on the strains that were really common the year before. So that's why year to year the flu vaccine isn't extremely effective, though it may be helpful at reducing people's symptoms from it or even reducing transmission of the disease. This virus is not mutating as fast as all that, but it may moving forward. And so that's why we're not really sure whether, if you caught the virus now, are you going to be immune for a short term or long term? Not really well understood yet. Are we going to see another peak come wintertime? Again, not really understood yet. And so there's still a lot of question marks to sort of fill in the blanks as we go and learn more about this disease. How was that, Verona?
That was perfect. I heard that it was the transmission took place by someone eating a bat, and all of these kind of myths and urban legends that we're hearing. But it's good to kind of get the information, as much as information as you can, as you know, of how it happened and how it's being transmitted, what we know right now. So the next question I have for Betty Hillard, and Betty, you have those numbers from the Minnesota Department of Health, and so just going over the numbers, what is the statistics for African Americans having COVID-19 in the state of Minnesota, and kind of merge with medical doctor McKinney and what you said. What are we looking at? What are our statistics?
So as of yesterday, June 8th, we had 28,224 cases, confirmed cases, and we have 1,197 deaths in the state of Minnesota. In those cases, 10,000 of them are confirmed cases, 10,000 are white, and 6,207 is Black. We already know that African Americans is just a tiny percentage of the people here in Minnesota, and we have over 50% of the cases, confirmed cases. And so that is a health disparity. That is COVID shining its light on the inequities that we've been having in this state all the time. And so we've always known that we've had these disparities, but COVID has just shined the light on how big a difference it is in what we see in African American health and what we're seeing in the health of other populations. And I'd like to just share that I'm going to share all the ethnic groups and how many cases have been confirmed by groups. I said 10,000 for whites, 6,207 for Black. In the Asian community, only 1,870 cases have been confirmed. The American Indian community, only 229 cases have been confirmed. And the API community, Pacific Islander specifically, there's only 67 cases in those communities. So we see that African Americans are being disproportionately affected by this COVID and the confirmed cases. There are other groups and unknown groups with high numbers, and those numbers, they didn't get the contact information, so they don't have to do case investigations on them. Then groups that multiple races is 549 cases. So we see that we are being so disproportionately affected by this. And even when you look at ethnicity, Hispanic community, 6,097 cases, and non-Hispanic, which is mostly white, 5,766 cases. So we know that when you overlay race with anything, you're going to compound any issues that you have. And then I wanted to share the congregate living statistics. There's 6,274 cases that have been confirmed by exposure in congregate living situations. And then in community known, exposure is 8,497, which is why we have to do this testing that we're talking about today, because community spread is way higher than any other way that this disease has been spread. And so we really need to reach the community to let them know how to prevent the spread of COVID.
I have a follow-up question. As you start to detail the different ethnicities and the different races, how important was it to have that data segregated? I know that here in Minnesota, surprisingly, I got this answer so many times during presentations that we don't segregate, we segregate data. We just kind of lump everybody in as people of color, and no one ever challenges us to you came to CFS Verona and you started saying, well, how many Black people we have that's participating in a program? How many Asian people? How many? I started calling them that, and it was like we just lump everybody all together, and they never said anything, they never complained, they never just said that they wanted separate data. I think it's important, but I want you to speak to the importance of that, Betty.
It's very important that we desegregate the data. And we here in Minnesota at the Department of Health, we decided right away that we would desegregate it by race. We knew that there were a lot of states that was not doing it. I think at the time that we started doing it, only Illinois and um, Michigan maybe were the only other two states that were desegregating data by race. And so I specifically asked for that because I know it's something that we're going to need. And there's been so much data that hasn't been desegregated and given back to the community. And that's why we don't know what's going on and how to fix problems because we don't have the data. And they keep saying, oh, well, it's such a small sample that we can't desegregate it, and that might be true in some cases, but I think that as public health officials, we have to find a way around it. We do need to desegregate the data so that we can know exactly what's going on where and know where the problem is so that we can fix it.
Thank you so very much. That's very important. I can't stress that enough. And by desegregating the data, it doesn't mean that you're taking attention away from other racial or ethnic groups. It means that we need to know where those pockets are. We need to know where people are in need, and that gives us a clearer picture. Right now, I'm going to go to Devin Gilchrist. I'm going over to Devin. Um, little crystal ball that I can actually go right over to Devin. Devin, what's the vision for the African American Child Welfare Unit as it pertains to COVID? I know you talked about having a group. What exactly is that specified to do here?
Yeah, I guess I'll just clarify a couple of things. So with the child well-being unit in terms of DHS, that's focused on child welfare. But our work group within DHS is focused on a number of different things, pertaining to COVID and the community. What we're looking at is how do we better make sure there's access to the needs, the things they need to get to this process. And so, working with Betty's group is quite a big part of that process. And I know she's playing some of the things she's doing as well. But also getting them access, things that we're doing at DHS, so they understand how childcare has changed now in terms of services that are there and the different parameters we put in place to help folks through the process to access childcare while kids are not in school anymore or over summertime, those kind of things. Looking at how we change the support since we have access to that. So we have a person from economic support from recent days, create some mechanisms to support lunch during the summertime because we have kids that are now not going to summer school programs, not going to Part1 programs, not involved in camps, thing they usually do in the summertime was not home. And many of these students and these young children, have out to eat. And just the impact of that on families it can be a burden for folks who are already struggling financially to make their ends meet and meet their needs. And so that kind of thing, looking at mental health and folks have access to mental health services, this has created the um, the scenario of folks who are now living with their kids and their families in close quarters. Let's be very honest. Much we love our kids and our families, being around them 24 hours a day can be a lot for your mental health, and you need a break. You can feel conflicted, and that's just human nature. It doesn't do being a good parent or bad parent. It's just how we are as people. We need breaks sometimes from our friends, our families, just to disconnect and just recalibrate. And so, how do folks have access to things that are going to ensure their well-being through telehealth, through video services and Skype, and other things that will help them maintain those processes for kids who are disconnected from their families, their schools, their friends, their social communities, their jobs. My daughter didn't go to work for almost 3 months, because of this. And so, how do you help these individuals and families with this process as well? So, really, the big thing is, I think, just education, access, understanding, creating those collaborations within the community. I think we've done a good job really engaging community agencies, ALF and Urban League and United Way, other agencies that can help spread the word, faith-based communities, smaller communities and individuals in the community that can actually spread the word around COVID services, testing, access to PPE, other resources too. So just trying to find a way to bridge that gap and also think about long term. I think that we have to look at this as a longer game. And this is not going to go away anytime soon. thinking about the effects of people who've been doing this for now 2 months and on throughout the summertime into the fall. What will it look like? What will be the impact on people's lives long term, financially, economically, socially, recreationally, spiritually, mentally, all those things. And so our work is really charged at using the really excellent array of services, expertise we have at DHS from folks who know the community, they're from the community, they understand the community, and they can actually really make sure that those needs are met, both internally and externally too, as well. So we'll continue to do that work. We'll continue to move on and partner with folks as we go through this process and get through the pandemic. But the biggest thing is, using our collaboration and innovation and also resources to really streamline what we're doing to really make sure the community is supported throughout the process, not just short term, but also long term too. And they don't fall victim to adverse effects like career child protection, because now they have some financial pieces because they've had a kid at home all summer and they are struggling financially, or their mental health is so impacted that now there's a conflict in the home that leads to a police intervention. And we know how those things go, obviously. So trying to find the resources to prevent other potential adverse effects down the road for these families who are already dealing with enough as it is, just being African American and dealing with the pandemic that hits the community so hard.
I think it's so important and so critically important that we have now to recognize that beyond this pandemic, we have other systemic problems or issues abound actually in the community, and that now employees are going in and saying we have our work that we're assigned to do around our regular work and servicing families and communities. And on top of that, now we have our COVID lens that we are also engaging with our families and children and families on the COVID level. So it's compounding in the community. Thank you so much, Devin, for putting that in perspective. And I'm going to throw the ball over to Karen McKinney, Dr. Karen McKinney. I just set the framework of as employees, we're not only dealing with the task of being employees, servicing our community and families and children and the public, but now we are also looking at our work through a COVID-19 lens. What could we be doing? What is happening at DHS regarding repairing the environment where Black people were treated unfairly? I think that sometimes that's at the root of the systemic issues that we don't like to talk about. We have an impact on health, on well-being, on stress levels. So what are we doing here at DHS to prepare to work in those communities?
Thank you. First thing I want to say is that recognition that the culture and environment at DHS needs to change. That's a big step in the sense that in prior years, I'm not sure that people recognize that how difficult it is to be at DHS and be a Black person, be a Black employee, and that there's something going on there. So now we do know that. This commissioner is bringing in a focus on anti-racism, and anti-racism is about analyzing our racist culture and systems and institutions and committing to dismantling those things. And taking on anti-racist identity that rejects victimhood and stands in a place of empowerment with a voice and using that voice. So one of the things as it relates to COVID-19 is that all of these, that called for DHS to revise more than 70 policies or laws, and they had to change. And so because they had to change, now we have added an equity lens that's been applied to all of those changes. So questions like, how will this impact the communities of color and indigenous communities. Who benefits from this, and who gets left out? What's going to be the impact afterwards? And these kinds of questions had not been asked when these laws were put in practices and policies were put in place. And now they are. And so because of that, different decisions have been made. And I have seen decisions get reversed. I have seen us listening to the communities of color and then going in and making a different decision because we listened. And so one of the biggest learnings that we're taking from COVID-19 is that not only does an equity lens need to be added to this stuff, but it should always be added. And so we're making a commitment that this is what's going to happen. In my mind, I don't know if I can make this happen, but in my mind, we need to hire a full-time person whose job it is to just look at the policies that we bring to the legislature. Say, we've done this with an equity lens, and just review everything. And they should be added to that legislature staff that deals with that. That's an epiphany that I have had just in 5 months that I've been here. So when you think about the rest of the question, what else is going on? So the anti-racism strategic leadership team that we had talked about when I first came, they have actually been formed and they are starting this month. This is the team that has been charged with transforming the culture at DHS and guiding us into becoming an anti-racist institution. Trainers have been identified to facilitate what will be a mandatory orientation for all that to learn about anti-racism. The strategic leadership team will participate in anti-racist training next month so that they are all operating from the same theoretical framework. You cannot train away racism. You cannot educate away racism. You have to strategize. And it has to be done institution by institution. So this team is going to look at this institution, DHS, and work on what strategy are we going to use. And they're going to come up and formulate that strategy so that we can actually change this. Next month, hopefully we're trying to roll it out next month, all of the executive team will take the IDI, which is the Intercultural Development Inventory, and they will start working on their own cultural compass. It will be the first group of leadership that will take this inventory, and this will be coming out next to managers and then directors. And so not only will they take it, but they will have to write their own goals on becoming more culturally competent. Those goals will be rolled into their annual review so that they're held accountable for this. This is about putting in some steps that will make this changes that we want to make, institutionalize them so that they will become part of what DHS is. I think I'll stop there. I think I took enough time.
Thank you. Thank you for setting the tone. And we have some questions that I'm going to open up to our CFS equity person who's been collecting our questions. If you would just come on and take some of the questions. One of the questions, Leslie, before you do that, one of the questions or statements that was made in the chat is that for medical doctor McKinney, how is this specific COVID-19, how is it impacting Black people? I can just say, the majority of the people who are on this WebEx audience is not Black, and they notice that the panel seems to have jumped ahead to how our community is now dealing with COVID. But please take a step back to explain why we are most impacted by this deadly virus. And they asked if Dr. Dr. McKinney can explain, I guess, with mobility in detail to provide this audience with better context. So I think that's important, and I'm glad that the audience member went straight to the question because usually in Minnesota we don't confront race and we don't confront things that we need to confront, and it's right there, it's the elephant in the room. So thank you very much, Robin Shines, for putting that information out there. Now we're going to deal with the elephant in the room. Why are Black people being impacted by this virus more than anyone else?
Yeah, thank you, Verona. That's a really important question, and I could probably spend the next, whatever, 67 minutes we have left talking about it. So be sure to play some Oscars music to, walk me off the stage whenever you're ready. No, I'm just kidding. Um, to start with, I think Betty Hiller did a good job of introducing some of the data about how that works. I'll maybe present some more data on it just really quickly. We see in New York right now 2 times higher rates of deaths due to coronavirus, New York City, that is, for blacks compared to whites. Here it's about maybe 1.5 times or a little bit less. In our neighbor, Wisconsin, it's actually 18 times higher, actually 18.5 times higher. And I'm not sure what they're doing over there that's causing that. But suffice it to say, we're seeing a disparity in how blacks have been affected both by deaths and just by contraction of the illness or development of more severe disease. That's for sure. And that's also across other communities of color as well. So why is that? Well, it's I think interestingly, this came up when I was actually talking to Al McFarland and some other folks on Friday, and people had brought up the point that early on black folks said, well, gee, maybe we can't even catch this thing. Well, it turns out that certainly wasn't true, and some people even early on said, well, gee, coronavirus is kind of an equalizer. Viruses aren't racist, and I guess that's true too. But the outcomes of viruses may be, and why is that? Well, it's not that blacks or whites or anybody are more or less likely to actually contract the disease from an immune system perspective. Maybe because of people's individual medical conditions that could be the case, but ultimately, some of the same issues of structural racism that led to George Floyd's death led to some of these same problems. I think what we saw with George Floyd and what we see with coronavirus and what we see with a lot of other disparities in health outcomes are all symptoms of the same problem of structural racism. So to give you some very specific reasons as to why that would be, let's look at how living spaces differ for the black community versus the white community. I mean, institutional and structural racism has led to more densely populated areas for people of color. Residential segregation in general has been associated with adverse health outcomes and chronic diseases. Some of this is also related to issues of environmental justice, where you have higher rates of air pollution in lower socioeconomic areas or areas more predominantly where predominantly more people of color live. These are issues of diabetes, high blood pressure, heart disease, asthma, infant mortality. We see those disparities across the board. We also see for communities of color, and particularly the black community, lower rates of home ownership and lower rates of educational attainment. And that also is associated with higher disparities in chronic disease, quality of life, and healthcare utilization. We see that black people live generally further from stores and further from clinics. In terms of, the space, somebody mentioned this on the call already, often communities of color and again, black communities may be more multi-generational households. So you have more people potentially living in closer quarters there as well. We see overrepresentation of black people in places like jails and prisons and detention centers. So congregate living spaces where people are going to be closer together and more likely to catch the virus as well. With respect to work, my own area of interest and expertise, a lot of black people work as critical workers. Some of that data I was talking about that my department's looking at about injury rates in workers showing that we actually have higher numbers of black people working in healthcare sectors, and they're getting injured at higher rates, like not related to coronavirus, but just in general. And that's, work we're working on publishing sometime soon. We see that, there's less access to sick and paid leave for black workers. So they might be more likely to say, well, I'm sick, but man, I got to go to work because I'm going to get laid off. Otherwise, I can't pay my rent. And that's, no matter who it is in general, as a work doctor, I tell you, please, take time at home if you can. But Again, these are realistic barriers to people actually doing what they're supposed to be doing. We also see access to care being an issue. Lack of access to insurance, which is twice as high for Black versus white patients. Again, we talked about higher rates of chronic disease in Black versus white patients, and overall just systemic inequalities in care. And then, most importantly, both because of all the reasons I said and have led to all the reasons I've said, a mistrust of institutions and of healthcare institutions on the part of Black people, some of which came from what we saw with the Tuskegee experiments, where they were looking at the progression of syphilis, and once antibiotic treatment got developed, they did not give it to these people. And we found out about that as a Black community, and it was not something that we were pretty excited about, and appropriately developed some mistrust in that way. We saw another famous case with Henrietta Lacks and her cells being used for research, and her family not finding out about this for years or decades, and still not really exactly understanding the implications of cloning DNA and cell lines. So all of these things have led to a significant degree of disparities amongst Blacks and whites with respect to coronavirus, not only contraction of the disease, not from a medical but a social perspective, but also the development of more severe disease and the development of death. What you mentioned, Verona, and the other Dr. McKinney correlation, I'm surprised I never met her before this. These would be what are deemed by the World Health Organization, the WHO, no, just kidding, would be called social determinants of health. And so these are all the ways in which individuals are impacted by everything outside of medical conditions. And we see this in my field of occupational medicine and medicine generally, that the social determinants of health, the living, the work, the environment, everything around people, are actually greater drivers of health than our ability just to treat them with medicine or do surgery or whatever it is that we're supposed to do. So that was a long answer, but I want to say one last thing, which is nowadays, we think about public health and prevention, and so public health and prevention deal with sort of like populations. There's now even more of a focus on lifestyle medicine. I hope I could say a little bit to some degree. This might have been what Surgeon General Jerome Adams was getting at, but he may have delivered the message a little bit wrongly. But essentially, lifestyle medicine is concerned with individuals for themselves taking care of diet, exercise, sleep, mental health, and interesting social connectedness, which is important now during coronavirus. So people can think of physical distancing rather than social distancing. Still good to have friends. But when you think of those 5 domains, the reason I point those out is, diet, exercise, sleep, mental health, social connectedness. How many of those do you think affect Black people worse than they affect white people for everything? So with that being said, again, I think what we're experiencing with coronavirus, as with other diseases, as with other issues of social justice, are all symptoms of a larger problem.
Yep.
Is that too much, Rona?
You summed up our work as equity directors. Trust me, you have summed it up, and you and Karen McKinney, the 2 McKinneys, I'm going to say, that's our work. We need to look at it from a systemic issue, and tackle it that way. State legislature, our laws, our policy, our procedures, our practices, and how do we adapt those 5 pillars that you talked about, Dr. McKinney, on our physical distancing and the things that we have to do to keep our bodies healthy. And it's unfortunate that we have to do this on top of the other issues that we face as African American Black people. And so thank you for bringing that out. Right now, we have questions from our audience.